Thank you very much. Thank you to SAGES for allowing us to present this. Here are my disclosures. All right. Well, we all, probably are aware bariatric surgery is on the rise. We'll see with the GLP-1 agonists what impact that actually has. But leaks are certainly an impact in survivability or mortality after bariatric surgery and increase your mortality significantly when they happen. So have a significant impact on bariatric practices. When I'm identifying a leak, there's a lot of different factors that go into how to best management. The first and foremost is going to be stability. So is your patient stable or not? The unstable patient, again, we're surgeons, probably needs to be in the operating room. Stable patients, you have some time. The sort of pseudo-stable, again, those are your ICU-based patients, and I'll go through my algorithm in more detail in a minute, are the ones that we resuscitate and then can perform endoscopy sometimes in the operating room, sometimes in the ICU at bedside. Timing. So Dr. Rosenthal has categorized, and others have categorized the leak after bariatric surgery. Acute leaks are certainly a lot more easily dealt with endoscopically than long-term chronic leaks defined as those over 12 weeks in duration. Acute or subacute leaks, so think fresh surgical problems, are generally a little bit easier to manage endoscopically. The size, and certainly I will show you some videos of leaks that are best managed with a variety of different techniques. The location, how accessible is the leak or the hole to your visualization. So sleeve leaks, most typically are high along the fundus, up in the proximal stomach, and can be a very difficult place to access endoscopically. And then combining that with, relative distal obstruction, which is, some think, the pathophysiology of most sleeve leaks, where you have a relative distal obstruction and relative ischemia up top, and you end up popping. So distal obstruction. So these are all things that we need to think about when we're approaching your leak and leak patient. Cross-sectional imaging, so CT imaging, again, if stable. Barium swallow, again, if cooperative. Endoscopic assessment, critical. Of course, we're talking about endoscopic management, so being able to see it is important. And then one thing I would like to also talk about briefly is just enteral versus parenteral nutrition. And so we saw a number of different videos and means through which we can provide nutrition. So enterally, and consider that. Again, if we're going to operate on these patients, again, at the time of surgery, consider, placing a distal feeding tube, either endoscopically or with traditional surgical management, just because it will buy you some time, and some of the patients will be very happy to have less tubes chronically in their nose or in their mouth. So my leak algorithm, so this is, in putting this together, kind of how I think about leaks. So we suspect a leak. So your patient either comes into the emergency room or is on the floor. They're tachycardic, hypotensive, and freshly post-op. First thing I assess is their hemodynamic status. And so again, your unstable patient is usually going to the intensive care unit, or if very unstable, directly to the operating room. And we will treat that surgically. Once in the unit, we certainly work on resuscitating your patient. So broad spectrum antibiotics, IV fluids, blood products if need be, correcting your underlying chemistries. And then the benefit of being in the ICU is oftentimes that's a great place to perform an endoscopy, and so I'll cover that in a minute. Your stable patients, again, we have a little bit more time, so that's patients that we're going to get usually a CT scan with oral contrast or an upper GI. So that CT scan, oral contrast, upper GI, we confirm a leak. So how do I go about managing it? Well, it has to do with a little bit how well is that leak controlled. If it's a localized leak or abscess with just some mild peritoneal irritation, that is something that can be managed endoscopically. If it's uncontrolled, again, consider surgery, certainly if they're unstable. But that's where external drainage, I think, is valuable. So that is where I involve my IR colleagues, get control of that leak, get control of that peritoneal irritation, which, again, will then allow me to move into some of the endoscopic tools that we have. And so management, so this is the way I think about management. So they're internal drainage, and I'll go over the double pigtail, evac, and septotomy. That is ways we internally drain a leak cavity, stenting, and I will cover that as well. Endoscopic clipping versus suturing are options. And again, we've heard about through the scope clips and over the scope clips. And then tissue sealants. And this video is a leak that we inherited. And let me see if I can play that again. And it actually shows, let me go back. There we are. It shows just a large ischemic portion of this patient's re-sleeve. So this is a patient who had had a sleeve about 4 years prior, went and got a second sleeve, and in stapling that second sleeve, you could see there's a large area of wedge of the stomach that's simply ischemic. So how do we best manage it? So endoscopic internal drainage, the double pigtail stents. I like this in patients who have a small orifice into a contained cavity. So this is, again, with a small opening, you're converting basically your drainage, so you have an IR drain sometimes, and placing the double pigtail stents. This is done with a combination of endoscopic as well as fluoroscopic guidance, wire guidance, and Seldinger push technique to deploy the double pigtail stent through the opening. The external portion of the stent sits in your leak cavity, and this essentially drains or facilitates drainage of that leak effluent back into the stomach. It's useful because it's very helpful because patients tolerate it generally a lot better than they'll tolerate other things that I'm going to talk about, which is evacs and stents, because they don't have a tube chronically in their nose. They don't have the pressure sensation that you get sometimes in a stent patient. You don't have the migration risk or as big of a migration risk with the double pigtail stents. This has been adopted quite widely throughout Europe, and there's good data suggesting that this has almost entirely replaced, in some studies, the use of stents. The next device that I use is my endoluminal vac, and so this is your it does require general anesthesia for placement. You can kind of see at the top picture there what it looks like. When I create that, it's a NG tube that is up through the nose, pull it out through the mouth, and then through and around that suture the vac sponge to it. It's a labor-intensive procedure. It does require general anesthetic in my practice to place it because, again, you're placing not only the endoscope back through the mouth, but then this large sponge. As mentioned earlier by others, the placement of it into the cavity can be a bit of a challenge, and graspers are certainly helpful in pushing and pulling it down. The suture there at the end is used to control it and kind of drag it down through the esophagus into the orifice. This is at the bottom of the screen, the same patient who, again, that large part of the stomach went on to fully necrose. The right-hand picture is the same patient after the first vac exchange, and so you can see we've now basically debrided that entire cavity and allowed for better delivery of blood and healing properties to this large cavity. And in my experience, I actually really think it's helpful because it does provide really nice source control. So the vac, when we connect it, again, I just use your routine vac that we're all used to placing on open bellies and other things, place it at about 75 millimeters of negative pressure, which is just the lowest setting on that. And in my experience, it does provide fairly significant source control because, again, you're evacuating now that from the patient rather than letting it just drain internally. You'll see the patient respond, again, in my experience, relatively well. The last endoscopic internal drainage that I'll discuss is septotomy. And so this is, again, here you can see a sleeve leak with the sleeve and the distal stomach in the upper right-hand corner of that picture. The leak cavity is on the left-hand side. Septotomy basically converts that external cavity and facilitates better drainage internally. It's similar to what we do in colorectal surgery for pelvic abscesses or anastomotic leaks in low rectal procedures, where performing that septotomy creates a common channel, then through which all of that nastiness can now drain internally. They do require often serial endoscopic assessment. So again, going back, this is when we inherit these. These are not a one and done type of patient. We are often, when I get a leak that comes in, to the ER, I tell the patient, plan to be here for about a month to 6 weeks. It's surprising because their elective bariatric procedure is now, resulting in a month and a half stay in the hospital. But, that is just the nature of the beast. So serial debridement, serial endoscopic assessment, and the data with these show that actually usually one approach might not be the best. And I'm going to go over some of the other things I think that are probably less favorable. Endoscopic stents in managing leaks have certainly been described. This is one of the earlier descriptions of that. And it's about 70 patients with really good endoscopic leak closure rates with stents. The criticism of some of these things is that often these patients do go on to require surgery. Again, almost 10% of these patients did require a surgical revision. Due to the stent not working. The migration is a very common problem with stents and can be seen in upwards of 20% of patients with a stent. And stents can end up in all sorts of different places, requiring either emergent endoscopy to retrieve it or surgical intervention to remove a stent that's lodged where you don't want it. Between 6 and 8 weeks is the optimal time to remove it, removal is done just electively once the patient has shown that their leak is healed. We've heard a lot about endoscopic clips and over-the-scope clips. So these are not the TTS clips that let me see if I can get this to play. These are not the TTS clips that we've seen for some of the closure, but these are now large, again, the over-the-scope Ovesco or others, the bear claw clip. Again, acute leaks are more well tolerated and will close a lot more easily than chronic leak. This is actually our experience several years ago in treating leaks. The over-the-scope clip, I'll say, is useful for kind of pinhole openings. You want to debride, and that was what the video was supposed to show, was the pinhole opening here that we get with the leak. Again, it's a bulky device, and so proximal leaks or retroflexion and accessing that with the over-the-scope device can be a challenge. So again, location of the leak is really important in determining the best therapy for it, which is partly why stents, I think, have fallen out of favor, because getting a stent to oppose a leak is a really challenging thing. And those of us that have tried it, yes, on occasion you will get one to heal with it, but I think there are some other better devices out there. Similarly to the over-the-scope clips, suturing can be, again, something that is used. There's the Apollo EndoStitch device. There's the X-Tac device. Again, accessing the leak opening or orifice is kind of the challenge in these situations, and that's why that is a challenging thing to use. Anyway, so I want to thank SAGES and thank you for your attention.